Stop what you are doing right now and listen carefully, because what I am about to share with you could literally save your kidneys and possibly your life. If you are over 65 and currently taking more than one prescription medication, and let's be honest, most of you are, then the next 30 minutes might be the most important health information you hear this year. And I say that not to be dramatic, but because most doctors, including many primary care physicians, are still not warning their patients over 65 about these dangerous medication combinations that are sending thousands of seniors into acute kidney failure every single month. Let me tell you about Thomas, a 73-year-old retired firefighter from Portland, Oregon. Thomas was the picture of active aging. He walked 3 miles every morning, maintained his garden, played with his grandchildren every weekend. He was taking what his doctor prescribed, a blood pressure medication, an anti-inflammatory for his arthritis, and a diuretic for mild swelling in his ankles. 3 common medications that millions of seniors take every single day. Within 6 weeks of starting this combination, Thomas collapsed in his kitchen. By the time the ambulance arrived, his kidneys were operating at less than 30% capacity. He spent 4 days in intensive care and came within hours of needing emergency dialysis. The terrifying part? He had no idea anything was wrong until his body was in complete crisis. I am Dr. Richard Morrison, board-certified nephrologist, clinical researcher specializing in age-related kidney disease, and I have spent over 28 years studying how medications affect kidney function in aging adults at the cellular level. And today, I am going to break down the 6 most dangerous medication combinations that are quietly destroying kidneys in adults over 65, ranked from concerning to absolutely critical. By the end of this video, you will know exactly which combinations to discuss with your doctor tomorrow morning, which warning signs demand immediate medical attention, and how to protect your kidney function while still managing the conditions you need to treat. Before we dive in, I want to ask you something personally. Leave a comment below telling me your age and how many prescription medications you currently take daily. I read every single comment on this channel, and your answers genuinely shape what I cover next. This conversation belongs to you, and I want to hear your story. Now, here is why this matters more than you might realize. A landmark study published by researchers at Johns Hopkins University following over 62,000 adults aged 65 and older for a period of 8 years found something absolutely shocking. Seniors taking 3 or more medications simultaneously had a 47% higher risk of developing chronic kidney disease compared to those taking fewer medications. But here's what makes this even more alarming. The study found that certain specific combinations increased acute kidney injury risk by up to 312%. 312%. That is not a small increase. That is a catastrophic elevation in risk that most doctors never discuss during a standard 15-minute appointment. Your kidneys after the age of 65 are fundamentally different organs than they were at 40 or 50. Here is what is happening inside your body right now. After 65, your kidney filtration rate, the measurement of how effectively your kidneys clean your blood, declines by approximately 8 to 10 milliliters per minute per decade. Your kidney blood vessels lose elasticity and develop what researchers call vascular stiffness, reducing blood flow to the filtration units by up to 35%. The number of functioning nephrons, the microscopic filtering units inside each kidney, decreases naturally with age. By 75, you may have lost 20 to 30% of the nephrons you had at age 30. This means your aging kidneys are already working harder to do the same job, operating with reduced capacity and diminished reserve. When you add medications that stress kidney function, you are pushing organs that are already struggling into territory where they can fail completely. And unlike your liver, which can regenerate, once kidney function is lost, it is gone permanently. There is no reversing severe kidney damage. There is only dialysis or transplant. Coming in at number 6, and this combination surprises almost everyone I tell it to, we are talking about the pairing of ACE inhibitors, or ARBs, for blood pressure with potassium supplements or potassium-sparing diuretics. Now, I know that sounds technical, so let me translate. ACE inhibitors include medications like lisinopril, enalapril, and ramipril. ARBs include losartan, valsartan, and irbesartan. These are among the most commonly prescribed blood pressure medications in the United States, and millions of seniors take them daily. Here is the mechanism you need to understand. These blood pressure medications work by affecting how your kidneys handle potassium. Normally, healthy kidneys excrete excess potassium through urine, keeping blood levels in a narrow, safe range. But ACE inhibitors and ARBs tell your kidneys to hold on to potassium instead of releasing it. This is fine for most younger adults. But after 65, your kidney function has declined. Your kidneys are less responsive, less flexible in how they regulate electrolytes. When you add a potassium supplement, which many seniors take for leg cramps, or because their doctor mentioned their potassium was slightly low, or when you take a potassium-sparing diuretic like spironolactone, you are creating a perfect storm. Potassium starts accumulating in your bloodstream. At first, you feel nothing. No symptoms, no warning signs. But when potassium levels rise above 5.5 milliequivalents per liter, you enter dangerous territory. Above 6, you risk cardiac arrhythmia. Above 7, your heart can stop beating. I have seen this happen in the emergency room more times than I can count. A senior comes in feeling slightly weak, maybe a little nauseous, nothing dramatic. We run labs and their potassium is 6.8. We are placing defibrillator pads on their chest within minutes because their heart rhythm is becoming unstable. A study from the European Heart Journal tracking over 41,000 patients on ACE inhibitors found that those who also took potassium supplements had a 2.3 times higher risk of hospitalization for hyperkalemia, which is the medical term for dangerously elevated potassium. Here is the practical guidance. If you are taking an ACE inhibitor, or ARB, do not take potassium supplements unless your doctor has specifically tested your potassium levels recently and prescribed them. Avoid salt substitutes, which are often pure potassium chloride, marketed as a healthier alternative to sodium. And ask your doctor to check your kidney function and potassium levels at least every 6 months, not annually. 6 months. After 65, things change fast. Your doctor needs current data, not year-old labs. The synergy tip here is critical. If your potassium runs low and you genuinely need supplementation, work with your doctor to adjust your blood pressure medication dose. Sometimes a slightly lower dose of the ACE inhibitor allows your kidneys to release more potassium naturally, eliminating the need for supplementation entirely. This is precision medicine, and it requires a doctor who understands aging kidney physiology. Moving to number 5, we have a combination that destroys more kidneys in seniors than almost any other pairing. We are talking about NSAIDs, the non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, and celecoxib, combined with diuretics and ACE inhibitors or ARBs. This is called the triple whammy in nephrology circles, and it is responsible for thousands of cases of acute kidney injury every single year in adults over 65. Let me explain why this combination is so devastating. Your kidneys maintain blood flow through a delicate balance of pressures and chemical signals. When blood pressure drops or blood volume decreases, your kidneys release protective hormones that keep blood flowing to the filtration units. ACE inhibitors block one of these protective mechanisms. Diuretics reduce blood volume by making you urinate more. And NSAIDs block the production of prostaglandins, which are the chemical messengers that help maintain kidney blood flow when the other systems are compromised. When you combine all three, you remove every safety mechanism your kidneys have. Blood flow to the nephrons drops dramatically. The filtration rate plummets. Waste products that should be filtered into urine start building up in your bloodstream. Creatinine rises. Blood urea nitrogen climbs. And within days or weeks, you can go from normal kidney function to stage 3 or stage 4 chronic kidney disease. I treated a patient named Eleanor, 76 years old, from Memphis, Tennessee. She had been managing her blood pressure beautifully for years with an ACE inhibitor and a diuretic. Then she developed knee pain from osteoarthritis. Her primary care doctor, meaning well but not thinking about the kidney implications, prescribed naproxen. Eleanor took it exactly as directed, 2 pills daily. Within 3 weeks, she noticed her ankles were more swollen than usual. She felt more tired. She thought it was just the arthritis getting worse. By week 5, she was so fatigued she could barely get out of bed. Her daughter brought her to the emergency room. Her creatinine had gone from 1.1, which is normal for her age, to 3.7. Her kidneys were in acute failure. We stopped the naproxen immediately, adjusted her other medications, and provided supportive care. Her kidney function partially recovered over the next 6 weeks, but it never returned to baseline. She lost approximately 30% of her kidney function permanently because of a medication combination that nobody warned her about. Her cardiologist prescribed the blood pressure medications. Her primary care doctor prescribed the naproxen. Neither one was thinking about how the combination would affect her aging kidneys. This is not malpractice. This is the reality of fragmented care in modern medicine. A comprehensive study from Stanford University School of Medicine analyzed over 98,000 emergency room visits for acute kidney injury in adults over 65. They found that the triple whammy combination was involved in 18% of all cases. 18%. That means nearly 1 in 5 seniors showing up to emergency rooms in kidney failure got there because of this specific medication combination. Here is what you need to do right now. If you are taking a diuretic and a blood pressure medication that ends in pril or sartan, which are the ACE inhibitors and ARBs, you must avoid NSAIDs unless absolutely necessary. and I mean absolutely necessary. For pain relief, work with your doctor to try acetaminophen first, which does not affect kidney blood flow the same way. If you absolutely must take an NSAID for a severe arthritis flare or injury, use the lowest effective dose for the shortest possible time, 3 to 5 days maximum, and increase your water intake significantly during that period. Proper hydration is one of the few ways to partially protect kidney blood flow when these medications are necessary. And here is the synergy tip that can save your kidneys. Ask your doctor about checking your kidney function with a blood test before starting any NSAID, and again, 2 weeks after starting. This simple precaution catches problems early when they are still reversible. Early detection is everything with kidney damage. Now let's move to number 4, and this is where we enter territory that most physicians never explain to their patients. We are talking about the combination of proton pump inhibitors, the PPIs like omeprazole, pantoprazole, and esomeprazole, with diuretics. PPIs are the purple pill, the heartburn medications that millions of seniors take daily, often for years or even decades. And diuretics are the water pills prescribed for high blood pressure, heart failure, or swelling. Here is the mechanism that researchers at Harvard Medical School have been studying intensely over the last decade. PPIs change the acidity of your stomach, which sounds like that is the whole point for heartburn, but it has downstream effects nobody talks about. When you reduce stomach acid chronically, you interfere with magnesium absorption from food. Your intestines need an acidic environment to pull magnesium out of the vegetables, nuts, and whole grains you eat. Without that acidity, magnesium just passes through unabsorbed. At the same time, diuretics cause your kidneys to excrete more magnesium in urine. So you have a double hit. You are absorbing less magnesium from food because of the PPI, and you are losing more magnesium through urine because of the diuretic. After 65, your kidneys are already less efficient at conserving magnesium. This combination can drive your magnesium levels dangerously low within weeks or months. Low magnesium causes symptoms that most seniors and doctors attribute to other things. Muscle cramps, especially in the calves at night, irregular heartbeat, fatigue, weakness. But here's the kidney connection that is truly frightening. Low magnesium damages the cells lining your kidney tubules, the structures that reabsorb water and nutrients. This damage accelerates kidney function decline and increases risk of developing chronic kidney disease by 43%, according to research published in the Journal of the American Medical Association. I treated a gentleman named Robert, 68 years old, from Knoxville. He had been taking omeprazole for reflux for 12 years. His doctor added a diuretic for blood pressure control 3 years ago. Robert started experiencing leg cramps so severe they woke him up every single night. His doctor checked his magnesium level, something most doctors never think to do, and it was critically low at 1.2 milligrams per deciliter when normal is at least 1.7. We stopped the PPI, switched him to an H2 blocker for his reflux, and started magnesium supplementation. Within 8 weeks, his cramps resolved completely. But when we rechecked his kidney function, we found he had developed early chronic kidney disease that was not present before the medication combination. A landmark study from the University of California, San Diego, following over 73,000 adults, found that people taking PPIs long-term had a 20 to 50% increased risk of developing chronic kidney disease over a 5-year period. When you add a diuretic to the equation, that risk jumps even higher. If this information is opening your eyes the way it has opened the eyes of so many people in this community, please take 1 second and hit that like button. And if you are not yet subscribed, I invite you to join us. I publish evidence-based content specifically for people in their 60s, 70s, and beyond every single week, and it is completely free. Subscribe and ring that bell so you never miss a video. Here is your action plan for number 4. If you have been taking a PPI for more than 8 weeks, ask your doctor if you still need it. Many seniors are on these medications for years when the original condition has long since resolved. If you genuinely need acid suppression, ask about H2 blockers like famotidine as an alternative. They are not as powerful as PPIs, but for many people they are sufficient, and they do not interfere with magnesium absorption the same way. If you must stay on both a PPI and a diuretic, ask your doctor to check your magnesium level every 6 months and consider magnesium supplementation under medical supervision. The synergy tip here is about timing. If you are taking magnesium supplements, take them at least 2 hours apart from your PPI to maximize absorption. And focus on magnesium-rich foods like pumpkin seeds, almonds, spinach, and black beans, which provide additional kidney protective compounds beyond just the magnesium. Coming to number 3, we are talking about anticoagulants, the blood thinners like warfarin, or the newer agents like apixaban and rivaroxaban combined with antibiotics. This combination creates risk on multiple levels, but the kidney damage pathway is what I want you to understand. Antibiotics, particularly sulfa drugs, fluoroquinolones like ciprofloxacin, and even common ones like trimethoprim can cause what is called acute interstitial nephritis. This is an inflammatory reaction inside your kidney tissue, triggered by the medication. Your immune system mistakes kidney cells for foreign invaders and attacks them. After 65, your immune system is more reactive and less precise. You are more susceptible to this kind of inflammatory kidney damage. At the same time, blood thinners require your kidneys to metabolize and eliminate them from your body. When kidney function drops suddenly because of antibiotic-induced inflammation, blood thinner levels in your bloodstream can spike dangerously high. This creates a terrifying dual crisis. Your kidneys are inflamed and failing, and your blood becomes dangerously thin, putting you at risk for internal bleeding, brain hemorrhage, or bleeding into the kidneys themselves, which accelerates the damage. A patient named Dorothy, 78 years old from Baton Rouge, Louisiana, came to see me after a urinary tract infection sent her into this exact crisis. She was on apixaban for atrial fibrillation. Her primary care doctor prescribed ciprofloxacin for the UTI. Within 4 days, Dorothy noticed blood in her urine. Within 6 days, she was so weak she could not stand. Her kidney function had crashed from normal to stage 4 kidney disease, and her blood was so thin she had developed spontaneous bruising across her arms and legs. We hospitalized her immediately, stopped both medications, and provided supportive care. She recovered, but her kidney function never returned to baseline. She lost 40% of her filtration capacity permanently. Research from Massachusetts General Hospital found that seniors on anticoagulants who receive certain antibiotics have a 68% higher risk of hospitalization for bleeding complications and a 53% higher risk of acute kidney injury compared to those receiving other antibiotic classes. Here is what you must do. If you are on a blood thinner and you develop any infection requiring antibiotics, make absolutely certain your doctor knows about the blood thinner. Ask specifically whether the antibiotic they are prescribing has known interactions with your anticoagulant or known kidney toxicity. Request the safest option available, and insist on having your kidney function checked with a blood test within 1 week of starting the antibiotic, especially if you develop any unusual symptoms like decreased urine output, blood in urine, or unexplained bruising. The synergy tip for this combination is hydration. When you must take antibiotics while on blood thinners, increase your water intake to at least 8 to 10 glasses daily if your doctor has not restricted fluids. Proper hydration helps your kidneys flush the antibiotic through faster, reducing exposure time to the kidney tissue and lowering inflammation risk. This is one of the simplest protective strategies available, and almost no one does it. And now we arrive at number 2, the combination I teased at the very beginning of this video. This is something almost every senior in America encounters at some point, and most people have no idea it is destroying their kidneys. We are talking about contrast dye used in CT scans and certain X-rays combined with metformin for diabetes. Metformin is one of the most prescribed medications in the world for type 2 diabetes. It is generally safe and effective. Contrast dye is the iodine-based substance injected into your veins before certain imaging studies to make blood vessels and organs show up clearly on scans. Individually, both are usually well tolerated.